Good afternoon. The respected discussants and facilitators, the dear participants. Thank you very much for the IPD management for giving me the opportunity to present the this paper. For the next few minutes, I will be talking about the LPA, lipoprotein A, and it is one of the mysterious particles which is responsible for the pathogenesis of the atherosclerotic cardiovascular disease. It is still a mysterious particle. I will try to unveil as much as possible of the mystery of this particle. Though it has been described as before as 1963, and lot of papers, discussions, studies, publications have been made since for the last 4 decades. Say it is a first article 1981, 1986, there is paper, there is many papers. I just choose the papers, the main papers from the reputed journals. But still it is mysterious. What is it? It is a macromolecular complex in the plasma, and it was first described, as I have said, that in 1963. It is composed of molecule, LDL particle. It is LDL particle with which the apolipoprotein is attached with it. The two major protein components of the LP particles are ApoB100 and apolipoprotein A, and they are in the molar ratio 1:1. And atherogenic potential may be partially due to the observed correlation of the LPA level with the pro-inflammatory properties. This is the structures. You see basically it is the LDL particles with which there is a ApoA is attached with the LDL particle. Sorry. This is a consensus scientific statement from the American Heart Association in 2022. They said that the high levels of the lipoprotein are an independent and causal risk factor for atherosclerotic cardiovascular disease through the mechanisms associated with increased atherogenesis, inflammation, and thrombosis. And the main thing is that there is a lack of standardization of the assay of the LPA. Still, there is no standardization, and there is no harmonization of the assays. There is no universal guidelines for diagnosing and providing risk assessment, as well as there is no targeted treatment yet to be developed. And there is another consensus statement by the European Atherosclerotic Society. It is also published in the European Heart Journal in 2022. It is a causal as well as the continuous association between the LPA and concentration and the cardiovascular outcomes in different ethnic groups. Elevated LPA is a risk factor even at very low levels of the LDL. In this room, I was talking about the residual risk factor for the atherosclerotic cardiovascular disease about a year or 2 years back, where among the residual risk factor, one is this LPA, which is not measured routinely. Throughout the world, it is not measured routinely, and it is not possible in our country to assay it, but it is associated with both microcalcification and the macrocalcification of the aortic valve. Besides the LDL, the LP is also associated with the calcified aortic stenosis. And very low levels may associated with increased risk of the diabetes. And till now, as there is no specific lowering agents for the LPA, so the intensive or extensive management of the other risk factors are recommended when the LPA level is high. For general statements relating to LPA concentration, there is two units. One is the milligram per deciliter and another is the nanomoles per liter. In American FDA, they recommend the milligram per deciliter, but the Canadian Biochemical Society, they recommend the nanomoles per liter. And there is a cutoff value. One is the rule out value of the risk, that is the less than 30 milligram or less than 75 nanomoles per liter. It is the rule out. Another is the rule in value. More than 50 milligram per deciliter or more than 125 nanomoles per. That is the conversion rate is approximate 2.5. The consensus key points from the European Atherosclerotic Society are the high LPA concentration is causal for atherosclerotic cardiovascular disease, aortic valve stenosis, and the cardiovascular and all-cause mortality in men and women and across all the ethnic groups. The relation between LPA concentration and the outcome is continuous. Elevated LPA is a risk factor even at the very low level of the LDLC, and in children, and LPA more than 30 milligram per deciliter or 75 nanomoles per liter is associated with increased risk of recurrent arterial ischemic stroke. But the LPA is not a risk factor for the venous thromboembolism. This is the schematic diagram of the European Atherosclerotic Society. They say, you see, there is a very low level. It may associate with type 1 diabetes, type 2 diabetes, and it is not a risk factor for the venous thromboembolism, and this is the new risk factor for the aortic valve stenosis, and the relationship of the atherosclerotic cardiovascular disease and LPA level is continuous. The higher the level of the LPA, the higher the risk of the atherosclerotic cardiovascular disease. So, it is recommendation that the LPA should be measured at least once in a lifetime. In the end of my presentation, you will see that it is not valid now. It is valid when there is no anti-LPA agent. We thought that the LPA is a genetically determined and a fixed level. So once in a lifetime, you can measure the risk of a person. Interpretation of the LPA concentration should be in the context of the absolute risk, intensified risk factor management, and by lifestyle modification and the modification. And nowadays, there is a specific LPA lowering therapeutic agent which are under experiments, phase 2 and 3 trials. So this is the diagram from the European Heart Journal. You see the aortic valve stenosis, the higher the level, the higher the risk. In the ischemic stroke, this is the higher level. And this is myocardial infarction, heart failure. That is the risk of relative risk and absolute risk increases as a function of the increasing plasma LPA. And how the pathological mechanism is the pro-thrombotic, it is the pro-inflammatory, and it is the pro-atherogenic. So all these lead to the atherothrombotic phenomena, and also it may lead to the plaque rupture causing the acute coronary syndrome. So this same thing I have already shown. So I have already said that it is a residual risk factor, and about 20 to 30% of the general population have elevated LPA level. Individuals with LPA levels have a high risk of the cardiovascular disease or the ASCVD. And the LPA level more than 180 milligram, this is almost similar to the familial hypercholesterolemia. The same thing I have already said. The genetically determined low levels of the lipoprotein are associated with decreased risk of cardiovascular disease. Prevalence. The prevalence is about 27.9% of the patients are the more than 50, 20% patients more than 70, 12 or more than 90. These are the patients which a history of the myocardial infarction, ischemic stroke, and peripheral artery disease. So all these patients, they have got the higher level of the LPA. And this is the long-term cardiovascular risk. This is the published just this year in the JACC. The relationship of the LP with the SCVT outcomes in the more than 27,000 population, higher LP levels are associated with increased risk of the SCVT risk.